Hello, this is Dr. Rosen, Mark Rosen, and today we're going to be talking about abdominal scanning techniques using the ultrasound, specifically for the intensive care unit or the emergency department. Now, hopefully we'll accomplish a fair amount of material today. I know that you've all had some ultrasonographic experience, so we'll move somewhat quickly with the lecture so we can move on to hands-on experience. So today we'll have a brief review of which transducers or probes to use on the abdomen, and then learn which positions are advantageous to obtain these images. Advance our care by imaging a variety of structures including the liver, gallbladder, kidneys, Morrison's pouch, spleen, urinary bladder, some views for ascites, the abdominal aorta, and the IVC. So we have a fair amount of material to cover in a relatively short period of time. There are two major probes to use for the abdomen. They're both low-frequency probes. Remembering low-frequency probes can penetrate the abdomen to a deeper level, although the image is not as clear as a high-frequency probe. So what I would call the workhorse probe or transducer is the phased array, the P17 or the P21. The C60 or other curved array probes are extremely useful, but the P17 or P21 has the advantage of being able to be placed between the ribs. There are three major planes for scanning: the longitudinal and transverse plane, and then the coronal plane, which is often useful for visualizing the kidneys. So we'll go over each position somewhat rapidly here, and then we'll slow it down. So first, put the probe in the subxiphoid position in the longitudinal plane to see the heart and the tip of the liver on the right side. And then we slide the probe down to see the liver, gallbladder, Morrison's pouch, and the right kidney. For a better view of the right kidney, and sometimes for additional views of the gallbladder and ribs, we can move it to the coronal plane, but you have to deal with the ribs and go between them, which is why the phased array probes are better than the curvilinear for this particular view. And then again, you can move to the opposite sides to see the spleen and the left kidney, but you have to deal with the ribs again. And then finally, we can move the probe into the transverse position in the suprapubic area to see the bladder. Now, if this all seems like a lot to do, don't panic. We're going to take it slowly and one step at a time. So let's start. First, put the probe in the subxiphoid position in the longitudinal plane to see the right tip of the liver and the heart. And here you see the liver in the superior margin of the image, and the heart surrounded by a pericardial effusion. Over here is superficial, over here is deep, and we can see that we're viewing relatively deeply at 24 centimeters. It's important to always look at this particular spot here and make sure that you're visualizing at the right distance. And sometimes, as in this image, you can see the liver much more clearly. It's important to remember that in order to see the heart, you are visualizing your image by having the ultrasound go right through the liver. So once we get our location by seeing the heart and the liver, then we slide the probe to the subcostal margin and we can see the rest of the liver, gallbladder, Morrison's pouch, and the right kidney. And over here you see the liver in the middle of the image. The diaphragm, which will move up and down, appears as a hyperechoic, a white line, and the inferior vena cava will be an anechoic area. The normal liver is quite vascular, unlike the spleen, which is relatively avascular. And by moving the probe slightly, perhaps 10 or 15 degrees, the vascularity can become more prominent or less prominent. And over here we're watching hepatic veins emptying into the inferior vena cava. So again, skin superiorly in the image, the liver, diaphragm towards the bottom of the image, and the IVC with hepatic veins emptying into it. Now over here, this is the opposite side, and if just shown this image, one could be a little confused and say, is this the liver or the spleen? But note that the vascularity of the spleen is much different than the vascularity of the liver. It's a relatively avascular structure. Now, can you see the kidney, the fluid in the splenorenal pouch, and the general ascites? So take a close look at the imaging here. Spleen is large. And over here, this is free fluid or ascites. Here's the spleen. This is the kidney down here. Now let's freeze this image at a particular point. And right over here, this is fluid in the splenorenal pouch or the splenorenal gutter. This corresponds to fluid in Morrison's pouch if this was on the opposite side. If this was a fast scan, this would mean that the patient does in fact have fluid. For a fast scan, you're looking for blood typically in the abdomen. And it makes sense in this patient who has ascites that there would be some fluid here. It's important to note that you have to look for a second or two to make sure that there's actual fluid there, because the fluid can come and go as the diaphragm moves. Now over here, this is the opposite side on the right side, and this is Morrison's pouch, which is demarcated with the brownish colored arrow. And this is at the lowest point in the abdomen. It's the potential space between the right kidney and the liver. And it's again a potential space. Normally there's nothing there. It's just the cortex of the kidney leaning up against the liver in this image. If there's fluid, then it will appear anechoic or black. This scan does show positive fluid in Morrison's pouch, which we can see right over here. So this is a markedly positive scan, and again, this is kidney. You can see some of the pyramids in the kidney, and this is liver over here. The image being taken with this probe up here, and the ultrasound beam coming more posteriorly, which makes sense because the kidney is a more posterior structure as you move down. Now this is a picture where there's ascites at that large arrow. The kidney is being measured. It's relatively normal size, and you can see at the bottom of the screen on the left it's 11.4 centimeters. And the liver is cirrhotic. It's relatively small, so it's shrunken and scallop-shaped at the edge, floating in free fluid. Again, take note how avascular the liver is once it's cirrhotic. This can easily be confused with a spleen if the probe was placed backwards. And in fact, over here, one would think that's a spleen floating freely with in the ascites with bowels floating. However, this is the probe that's backwards in this image, so the cirrhotic liver is actually misplaced and should be on the left side. And should be on the right side. It appears on the left side.
Now, if we talk about the renal scan, you pretty much did one during the FAST exam, but you come over here, and you get a nice coronal view here of the kidney. You can actually get the kidney upper pole and lower pole on the screen at the same time here, and a long axis. And if you rotate the probe 90 degrees, you can get a short axis of the kidney, rotate the probe towards the ceiling, you get a short axis of the kidney fanning through. You always want to fan through an organ both its long and short axis. I didn't mention that with the gallbladder, but you want to do that with the gallbladder too. You want to fan through the gallbladder, it's long and short axis. But that's the kidney's long axis. Rotate the probe 90 degrees, there's a short axis. And again, on the left side, it's the same thing. Indicators towards the patient's head to get that long axis on the screen. And then to get the short axis, you rotate it towards the ceiling. Okay.
So again, thank you, Dr. Fox, a familiar face, I think, to everybody here. And just take note that you can obtain a scan of the kidney in the subxiphoid position, but it's sometimes easier to go in the coronal position. In fact, very frequently easier to go in the coronal position for the kidney. The ribs do get in the way, which is why we use the smaller phased array probe rather than the larger curvilinear probe. But it's oftentimes easier to see the kidney in the coronal image. especially if the patient has a lot of adipose. Now, a good button to know is the depth of field button. If we change the depth of field, then we can change the imaging. So here's a gallbladder, and take a look, we're at 15 centimeters, and over here is the size of the gallbladder, and we see it getting bigger and more clear as we move down to 11. This is simply a fold in the gallbladder that's coming and going with respirations. So again, we start off at 15, and then as we change the depth of field, the image becomes much easier to see and certainly easier to measure things such as the size of the portal vein, the anterior wall thickness, and so forth. So when learning about gallbladders, we're commonly looking for acute cholecystitis. And there are things that we would like to look in particular for this diagnosis. Number one, we would like to see a gallbladder that either has stones or sludge in it. We'd also like to see pericholecystic fluid. However, be aware that pericholecystic fluid and also thickening of the gallbladder wall will be seen if the patient has ascites. The anterior wall of the gallbladder should be less than 3 millimeters. And then we'd like to measure the common bile duct, which is oftentimes difficult to see, but with practice can be seen in most of the cases. The internal diameter, and again I emphasize internal diameter, because there is a certain thickness to the walls, the internal diameter should be less than 6 millimeters until age 60, and then we add 1 millimeter per decade. So for example, in an 80-year-old, a normal common bile duct or CBD should have an internal diameter of less than 6 plus 2, or 8 millimeters. But one has to be wary of calling acute cholecystitis in the face of ascites. As I just mentioned, there can be pericholecystic fluid and thickening of the gallbladder wall. Now, some things you can do to help make your diagnosis: if there is a stone, you can move the patient and see if the stone is stuck in the neck of the gallbladder. If the stone moves, then the stone is not occluding the gallbladder neck. Also, be sure to measure the diameter of the common bile duct, again being careful to measure the internal and not external diameter. And then check for a sonographic Murphy sign. If the patient is tender on exam, that's called a positive Murphy sign. And if the patient is tender in the right upper quadrant, by pressing the probe right over the gallbladder, and you can see the gallbladder so you know exactly where to press, that's called a positive sonographic Murphy sign, which is quite consistent with acute cholecystitis. Now there's a button to freeze the image, and that's important when we're taking measurements. And remember, you would like to ideally freeze the image in 2 planes. Now over here, I'm not exactly sure what they're measuring. It's supposed to be the anterior wall, but the anterior wall is very difficult to see. So by taking the image in a different plane, now we can see a very clear anterior wall over here, and that then can be measured using calipers. So a few things to note. Gallbladders can be in a variety of locations, so you have to somewhat search for it. They can have incidental folds in it, as you can see this over here. Those are totally normal findings, although the folds tend to be places where sludge can form or gallstones can sit. Decreasing the depth of field, as we mentioned before, by changing over here from 15 now to 11, can make the image more clearly. You want to examine the gallbladder in 2 planes, and the gallbladder should show posterior acoustic enhancement, as any hollow structure that's fluid-filled will have, such as the urinary bladder as well, posterior to the structure. If you can't find the gallbladder, think of a few things. Number one, a favorite for the residents to try to fool the attendings is look for surgical scars. And especially in today's times where you can have a lap chole, these can be very difficult to find. Sometimes you have patients that don't know their surgical history, rather surprisingly enough, or can't relay their surgical history because they're confused, unconscious, intoxicated, and so forth. If you can't find the gallbladder, roll the patient to the left side if you're able to. Another thing is move the patient to move the probe to what's called an X-7 position. X stands for xiphoid process, and 7 is 7 centimeters lateral to the xiphoid process and between the ribs. So then you're coming down anteriorly, and we can do this in the hands-on group and show you this in greater detail. But sometimes by coming from this position, you can land right on top of the gallbladder. And then at times try imaging from the coronal view. This is especially useful if the patient is overweight, and even more so, in my opinion, if the patient has abdominal gas. So cholelithiasis has shadowing of the stones. Now here I purposely picked an image that is not high quality to show stones here. You can see something, but you clearly see the shadowing coming off over here where the ultrasound beam cannot penetrate. There's something called the double barrel shotgun sign, where if you catch the gallbladder in this image, you can see that there are, between the orange colored lines, arrows, and the yellow colored arrows, there are two structures. The more anterior one is the CBD, or common bile duct. Between the yellow lines, the more posterior one is the portal vein. We're interested primarily in the CBD, again looking at the dimensions to see if it's less than 6 millimeters rather, for someone less than 60 years old. And again, we measure from the internal diameter of the CBD. Note that there is approximately a millimeter difference in this image on the wall of the gallbladder. To see the urinary bladder, use the transverse view and then the longitudinal view. And again, note this posterior acoustic enhancement over here. And here, there is some free fluid. Shouldn't have anything here. Here's the urinary bladder, and it's somewhat overgained. This should be perfectly anechoic here. And what's happening here is someone is putting color flow over here to make sure that this is not an iliac vein, which would be more in this area over here. But this is not an iliac structure. Foley balloon is in this bladder. In the ICU, you rarely see this image because you can just see the Foley balloon. The bladder is completely empty. In the emergency department, you typically don't see this image because when the patient comes in, the bladder is full. Once you have the Foley in, then the bladder rapidly empties. So here is a Foley in place, and you can see some shadowing from the circular Foley as well. And the bladder is emptying. In another 15-20 seconds, you'll just see the balloon in this one. So let's move on. Another structure in the abdomen, and I'm not sure if we should be covering this today or not, but I thought I would throw it in since I think we have time, is the aorta. Now normally we would have this as a separate lecture under vascular structures, but we'll cover it, and it's important to realize that below the diaphragm in the abdomen, there are three main areas that we look at: the celiac artery, the takeoff of the SMA or superior mesenteric artery, and the bifurcation of the aorta into the iliacs, which occurs at around the umbilicus. The renal arteries and the inferior mesenteric artery are rarely seen as they're too small. For the abdominal aorta, the probe is placed in the transverse plane just below the ribs, and then it's moved inferiorly towards the umbilicus, and again at the umbilicus is where the aorta bifurcates typically. So this is a seagull, and this is a seagull sign. Notice that the green arrows, it's not incredibly clear in this image, and I apologize for the quality, but at the green arrows is a very similar shape to the seagull. And this is the celiac axis as it appears taking off in the transverse plane from the aorta. If we move just slightly more distally, then we get the SMA, the superior mesenteric artery. And the superior mesenteric artery is seen on the right side of this slide. Above the round aorta is another round structure. It's often described as a mantelpiece clock. So if you think of a clock on the mantle at your grandmother or grandfather's house, you may remember this type of a shape. So let's take a look at some of these structures. This is the vertebra, and the ultrasound beam cannot pass through it, so we have vertebral shadowing. And now let's point out some of the structures. There's the aorta that is on the left side of the body, so screen right. The opposite side is the IVC. Above the aorta is that mantle-shaped clock with the black anechoic face, and then the mantle shape is the white structure around it, primarily fat. And the splenic vein can be seen crossing above the SMA, and it's typically seen as one long line. In this particular film, in this particular image, I wanted to point out that it can also be divvied up into two pieces depending upon the respirations. If this person would breathe in and out, you would see those two areas on the right and the left where it says splenic vein crossing above the SMA would unite to become one image. Over here, we're looking at the IVC, the inferior vena cava. You can actually see blood going through this, and a large IVC indicates that the state of hydration is rather large. So this is the plethoric IVC, an enlarged one, and you can see with color imaging that there's clearly flow in it. Over here, the IVC is collapsing, and you'll take note that it collapses with respirations. And this indicates dehydration. So it gets bigger and then collapses. And there's been a chart that's come from a few studies to point out the relationship between the right atrial pressure, or CVP, and the IVC size. Probably the more important thing to realize is that a small IVC, typically less than 1.5 centimeters, correlates to a dehydration, and a plethoric or enlarged one greater than 2.5 centimeters correlates to an elevated CVP, typically but not always associated with CHF. You can see increased CVP with other entities such as pulmonary hypertension, right-sided heart failure, pulmonary embolism, COPD, things of this nature. And we also look at how much it collapses. If it collapses greater than 50% with respiratory variation, the patient is dehydrated. So the measurement of the IVC can ascertain if there's severe hydration or overhydration, but it really doesn't give an exact CVP measurement. There is a way that I can show you on the hands-on, if you'd like, if we have time, how to measure a CVP by ultrasound, but we'll save this since it's not part of the abdominal lecture. So what to take home from all of this? So the first thing is you'll have to relearn some of the basic anatomy, or perhaps that's just for the attendings and you guys already know the basic anatomy. The next is the ultrasound is hard to learn from lectures. It makes a lot more sense once you have hands-on, so we'll leave most of the time for the hands-on sessions. Then always use two planes and proper orientation of the probe to see the ultrasound organs, typically having the probe indicated to the right of the patient or aimed towards the head for the two orientations. And then you can use depth of field or color flow to confirm vessels and proper imaging. And lastly, it's not a failure to ask radiologists for ultrasounds, especially in the more difficult case, such as this one. I really wouldn't want to be responsible for doing the abdominal ultrasound here. Hope this lecture was useful for you, and now we'll do the hands-on sessions. Thank you very much.